Alright, picking up with peripheral vascular disease. Peripheral vascular disease consists of disorders that change the flow of blood of the peripheral circulation and cause decreased tissue perfusion. Typically, it's an arterial problem, but it can also be a venous problem. Peripheral arterial disease results from systemic atherosclerosis. This causes blockage, which decreases perfusion to extremities. Peripheral artery disease in the legs is known as lower extremity arterial disease. Obstructions are classified as inflow and outflow. Inflow involves the distal end of the aorta and iliac arteries. With inflow disease, the patients have more discomfort in the lower back, buttocks, or thighs, and the pain is rated from mild to severe, resembling stage 3 rest pain, and we'll go over all those shortly. Outflow obstructions involve the femoral, popliteal, and tibial arteries. The patient typically describes burning or cramping in the calves, ankles, feet, and toes. The pain is mild to severe, experiencing rest pain. Gradual outflow occlusions usually cause significant damage. Atherosclerosis is the most common cause of chronic arterial obstruction. Common risk factors are hypertension, hyperlipidemia, diabetes mellitus, cigarette smoking, and obesity. Patients with peripheral artery disease have an increased risk for developing chronic angina, myocardial infarction, or stroke, and are much more likely to die within 10 years compared to those who do not have peripheral artery disease. Peripheral artery disease is divided into 4 stages. Stage 1 is the asymptomatic stage. There's no claudication present. A bruit or aneurysm may be present. Pulses in the feet are decreased or absent. Stage 2 is the claudication stage. That's when there's muscle pain or cramping with exercise. It's relieved with rest. And your book states that the symptoms are reproducible. What that means is that if someone walks 15 feet to the mailbox and they stop, the pain subsides. When they walk another 15 feet, that pain will occur again. Stage 3 is rest with pain. Pain while resting commonly awakens the patient at night. The pain is numb and burns. Occurs in the toes, arch, or heel of the foot. It's relieved by dependent positioning and can lead to limb loss. Stage 4, necrosis and gangrene stage. Ulcers and black tissue occur on the toes and the heel. An odor is present. Typical findings we can see in individuals with peripheral artery disease: loss of hair on the lower calf, ankle, and foot, dry, scaly, or dusky skin, thickened toenails. Extremities can be pale when elevated and cold when advanced disease is present. Rubor can occur when the leg is lowered. As nurses, we should be palpating the pulses and comparing them bilaterally. We want to note any signs of ulcer formation. Do read over chart 36-4 on page 721. Arterial ulcers are painful and develop on the toes, between the toes, or on the upper foot. MRA is used to assess blood flow in the peripheral arteries. Gadolinium is typically used to help visualize the blood flow. Exercise tolerance testing can be done. Interventions for these patients. Collateral circulation provides blood to the affected area through smaller vessels that develop and compensate for occluded vessels. Exercise improves blood flow through collateral circulation. Patients should avoid crossing their legs, and they should avoid wearing restrictive clothing. The individual should inspect their feet daily for any color changes. We want to caution the patient when using heat and not to apply heat directly because sensation is decreased with peripheral artery disease and they may not feel how warm their leg is getting. Exposure to affected limbs should be avoided, and refraining from tobacco products is beneficial for these patients. Drug therapy is common. Invasive non-surgical procedures can be performed. PCTA or atherectomy to improve blood flow. With this procedure, we want to watch the patient for bleeding at the arterial site and monitor for hypovolemic shock. With hypovolemic shock, we can see decreased blood pressure, increased heart rate, and decreased urinary output. Distal pulses should be palpated frequently for those suffering from peripheral artery disease. Patients typically receive antiplatelet therapy before and after their procedure. Surgical management, arterial revascularization. Surgeries are categorized as inflow or outflow. For outflow procedures, the patient's own saphenous vein is the preferred graft material. Pre-op care for these patients, we need to obtain a set of baseline vitals, pulses, we assess their pulses, and we need to make sure that these patients have more than one access line. Antibiotics may be administered prior to surgery in the pre-op stage or on call to the operating room. Post-op care, we want to make sure that these patients are encouraged with deep breathing and incentive spirometry every 1 to 2 hours. The patient should be NPO or nothing by mouth for at least 1 day after surgery to prevent nausea and vomiting if undergoing an aortoiliac or an aortofemoral surgery. If the surgery does not involve the aorta or the abdominal wall, the patient can advance to clears the day following surgery. Warmth, redness, and edema are expected outcomes. If you are working in recovery and you receive this patient, you will want to mark where the pulse is felt best or auscultated with a Doppler. We want to monitor these patients' blood pressure for decreases or increases from baseline to ensure that the graft is patent. Hypotension can indicate hypovolemia, which can increase the risk for clotting. Graft occlusion is an emergency that can occur within the first 24 hours after surgery. Continuous aching pain can be the first sign of graft occlusion and ischemia. Throbbing pain can be experienced because of an increased blood flow to the extremity. Make sure you are assessing the sensations and the quality of the patient's pain. Monitor the graft by checking the extremity often for color changes, temperature changes, and the intensity of the pulse. If the extremity becomes pale, cyanotic, or the pulse decreases, you want to contact the surgeon. Remember that range of motion is limited for these individuals. Emergency thrombectomies are the most common treatment for graft occlusions. Remember to use sterile technique when dealing with graft incisions because infections can be life-threatening. 5 to 7 days is typically how long the patient will stay in the hospital for a conventional procedure. With a minimally invasive procedure, the patient usually stays about 2 to 3 days. We want to make sure that we're teaching these patients how to manage themselves at home. Okay, that's very important. On page 724 and 725, there are charts. And if you feel like you need to read more on peripheral artery disease and how the patient should manage their care, you can follow up there. In the next audio, I will begin with acute peripheral arterial occlusion.